Good evening, Dr. Phil here. Today we will be discussing on awareness or accidental awareness during general anesthesia. The NAP5 reported that the overall incidence of AAGA is 1 in 19,000, 1 in 8,000 in patients given neuromuscular blockers. In patients undergoing caesarean section, it is 1 in 670. 50% of those experiencing AAGA report some form of psychological distress afterwards, the most significant of which is PTSD. AAGA can be divided into explicit awareness or implicit awareness. Explicit awareness is spontaneous or prompted recall of intraoperative events which may or may not include pain. Implicit awareness is some degree of cortical perception but without conscious recall. Case scenario: a nurse from orthopedic ward informs you that a patient you anesthetized 1 week ago claims that he was awake during his orthopedic operation, he is upset and wants an explanation. A guide to how to approach this scenario: introduce yourself to the patient, discuss in the presence of a witness such as a nurse, confirm the facts, listen to the history from the patient and finds out what does he recollect. Offer an apology and explains that all precautionary measures were taken such as machine check, choice of drugs, monitoring, etc. Try to explain why AAGA occurred. The patient was unstable following polytrauma. You had to be cautious with administration of the anesthetic drugs to avoid dangerous hypotension, and it was possible that during that period of hemodynamic instability that the patient had awareness. Find out whether the patient felt pain during his awareness. Mention that AAGA is rare but possible complication when anesthetizing unstable trauma patient. Arrange an interview with a consultant anesthetist. Offer follow-up after a week or a month after discharge. Offer to organize psychological support. Reassure that future general anesthesia can be safely provided. Explain that everything is documented and a letter about the incident will be written to inform his general practitioner and ask whether the patient wants to know anything more. Additional tips to manage the impact: be courteous, sympathetic and develop rapport. Keep conversation and procedures in the OT respectful to the patient. Interview the patient after the procedure and take a detailed account of the recollections. Assure that the patient is credible in his account. Notify the surgeon and other key personnel. The Bryce protocol is a post-anesthesia questionnaire used by anesthetists to detect awareness. It is based on a study by Bryce et al. In 1970. The timing of questioning can be either on waking in the following 24 to 48 hours or after 2 to 3 weeks. The Bryce protocol consists of 5 questions. The first question is, what was the last thing you remember before going to sleep? What is the first thing you remember on waking up? Can you remember anything in between? Did you dream during the procedure, and what was the worst thing about your operation? Additional questions for patients with post-op recall: what did you notice during the awareness? Did you feel something in your mouth or throat? Were you able to move? What went through your mind? Did you think you were dreaming? How long did it last? Did you try to alert anyone? Did you inform the anesthesiologist or hospital staff? Has there been any consequences? Do you sleep alright at night? Classification of AAGA can be either by Michigan Awareness Classification Instrument or Classification of Intraoperative Cognitive States. Risk factors for AAGA includes underdosing of anesthesia, use of neuromuscular blocking agents. Surgical factors includes cardiac surgery, cardiopulmonary bypass, emergency surgery including trauma, obstetric surgery. Patient factors includes severe aortic stenosis, pulmonary hypertension, ASA 4 to 5, cardiac EF of less than 40%, marginal exercise tolerance, long-term use of opioids, benzodiazepines, anticonvulsants and cocaine, daily alcohol consumption, protease inhibitor use, end-stage lung disease, pediatric population, previous AAGA. Anesthetic factors include use of muscle relaxants, underdosing of anesthesia, difficult intubation, prolonged airway management, and non-propofol, non-volatile based anesthetic techniques. Causes of AAGA. Equipments and apparatus. Failure of the apparatus to deliver adequate anesthetic agent, for example, faulty empty vaporizer, leaking breathing system, inadequate fresh gas flow, faulty TIVA syringe driver, occluded infusion tubing, misplaced venous cannula. Failure of the anesthetist to properly use the equipment, for example, inadequate fresh gas flow while using a circle system during the initial 15 minutes post-induction. Failure to monitor the concentrations of inspired and expired volatile agents. TIVA is more difficult to monitor because the effect site concentrations are calculated rather than measured. Pharmacology. The dose of the induction agent may be inadequate, as may be the alveolar concentration or the computed blood concentration in a target controlled infusion. Awareness is not prevented by hyperventilation, use of nitrous oxide, and opioids. Muscle relaxants are not anesthetics. Anesthesia should not be discontinued until their effects have been reversed in full. Patient factors. Rarely, a patient may be resistant to anesthetic agents. Possible risk factors include alcohol abuse, abuse of drugs, high anxiety, and the moribund patient that adequate anesthesia is incompatible with maintaining hemodynamic stability. The anesthetist should be alert to the clinical signs indicative of inadequate anesthesia. Airway problems and bronchoscopy. During a difficult intubation, the effects of the induction agent may wear off before those of the muscle relaxant. Patient is at risk of AAGA during some anesthetic techniques for rigid bronchoscopy, such as those using insufflation or injectors. Cardiac bypass increases the risk of AAGA. Prevention of AAGA. Preoperative and on induction. Evaluate for risk factors for AAGA. If present, consider increasing administered anesthetic dose if it is safe. Consider administering a benzodiazepine as an amnesic pre-medication. Check all equipments, drugs, and dosages. Ensure all drugs are clearly labeled and infusions run into patent veins. Redose IV anesthesia when the delivery of inhalational anesthesia is difficult, such as during a long intubation attempt. Intraoperative. Avoid administration of muscle relaxants whenever possible. If they are necessary, use the minimum dose. Monitor the degree of the neuromuscular blockade with a peripheral nerve stimulator and assess adequacy of reversal. Administer at least 0.7 mEq of the inhalational anesthetic agent. Set an alarm for low anesthetic gas concentration. Ensure adequate analgesia. If TIVA, ensure the settings are correct. Infusion tubing and machine not faulty. Dedicated IV line. Monitor depth of anesthesia. Post-traumatic stress disorder following AAGA. Mental distress is reported in up to 50% of patients experiencing AAGA. The most extreme of it is PTSD. Half of the patients paralyzed following administration of NMB develop features of PTSD. It is difficult to diagnose PTSD due to the resistance to further medical contact. Presentation can occur long time after the event. Patient may be reluctant to volunteer information about the traumatic event without direct questioning. Patient prefers to block out the painful memories, and this may affect males more than females. ICD-10 diagnostic criteria for PTSD. Exposure to a stressful event or situation of an exceptionally threatening or catastrophic nature, which is likely to cause pervasive distress in almost anyone. Persistent remembering or reliving of the stressor in intrusive flashbacks, vivid memories, recurring dreams, or by experiencing distress when exposed to reminders. Actual or preferred avoidance of reminders of the stressor. Either of the following. Number 1, inability to recall, either partially or completely, some important aspects of the period of exposure to the stressor. 2 or more newly arising persistent symptoms of hyperarousal, such as difficulty in falling or staying asleep, irritability or outbursts of anger, difficulty in concentrating, hypervigilance, exaggerated stutter response. For diagnosis, criteria B, C, and D should all be met within 6 months of the stressful event. Patients may be diagnosed with anxiety or depressive illness. Treatment of PTSD includes cognitive behavioral therapy and eye movement desensitization. Listening, patient reassurance, expertise, and attention to detail reduces preoperative anxiety and even risk of awareness. Audit of practice. All anesthetic departments should audit the incidence of definite or probable awareness. Ideal standard is that no patient undergoing GA should have awareness. However, in line with published data, the following targets have been recommended. For general surgical cases, less than 0.2% should have intraoperative awareness. For obstetric anesthesia, less than 0.4% of women should have intraoperative awareness. And for cardiac anesthesia, less than 1% should have intraoperative awareness. These are my references. Thank you.